begin just to discuss a little bit about neonatal opioid withdrawal syndrome and go over some of the terminology. Then I was going to discuss the two projects that we have tied to this COBRA grant itself, one being the Tri-Mor-Bup protocol and the other one being the perception study. So neonatal opioid withdrawal syndrome and neonatal abstinence syndrome, they're terms that have evolved over time. The definitions of the terminology as presented by Dr. State, but they're all really nested within each other. And so in the 70s with Loretta Finnegan and the establishment of neonatal abstinence syndrome, at that time period, opioid withdrawal was really the only identified withdrawal syndrome in neonates. And at that time, they classified that as NAS. Now, since the 1970s to today, we've realized that infants can show withdrawal patterns from many different types of substances. And because they can show this withdrawal pattern from many different types of substances, unfortunately, NAS kind of became the catchment term. And so now, when you talk about NAS, you have to be very clear, very specific about what substance you're actually referring to. Methamphetamines, antipsychotics, SSRIs, opioids, even nicotine is within that. So when families come and want to talk about NAS, it's very important to be clear about what is the substance that the infant is or the fetus is being exposed to. And it's important for the family to know that as well, because in today's information age, a family going on the internet and looking up NAS might get brought to a page about someone's story with in utero cocaine exposure, or in utero methamphetamine exposure. And those stories and those outcomes are going to be very different than opioid exposure. Because of our current epidemic, the term NOWS has really been coined. And over the past year to 2 years, they just started to take a forefront within the medical literature and the terminology. So when someone is wanting to talk about specifically opioid withdrawal, NOWS is the term that is used more, it is the more contemporary term to use. NAS would really mean many other things or any other substance. So when we talk about NOWS, we're really talking about the physical manifestation of a neuroendocrine dysregulation. So throughout the pregnancy, a mother is taking care of herself and her baby is being exposed to many different things. Fats, proteins, cytokines, interleukins, hormones, and within that is going to be some of mom's medications. Now, as the fetus is developing, their body is just simply responding to what is coming across the placenta. So when we speak with parents where there tends to be this concerns of guilt about hurting their infant or causing this problem for their infant, we really frame it in the concept of an adaptation. You're exposed to a medication that you're taking to help you during your pregnancy to have a healthy pregnancy, but your baby's body is just adapting to expect to see the same kind of medications that your body is seeing. Our job will be, once your baby is born, is to monitor the physical exam findings of your child to see if this adaptation has caused their body to respond differently. And if we're seeing the baby's body respond in a way that would suggest to us that they have adapted to expecting to see the opioid, our job will be to help them adapt back to not expecting to see the opioid. Now, in the context from the past talk of the question of babies born with an addiction, it's very common to hear someone say that. And what we try to do is redirect their thoughts. You know, an infant doesn't have the behavioral element usually tied to an addiction. They just have, or they could have, just the physical dependence. And because it's just a physical dependence, framing it to the family as adapting back to not expecting to see the opioid really helps to focus in that we're just dealing with a physical manifestation. We're not dealing with a behavioral change or a potential future behavioral change, which helps families frame out what we're doing in the care of their child in a very different light. They don't shoulder as much of the feeling that they're going to cause pain, changes, behavioral changes, long-term effects to their child just by simply wanting to have a healthy pregnancy and taking care of themselves. So in Rhode Island, our now statistics have been alarmingly high compared to the other states across the country. So in 2005, there was about 4.4 per 1,000 births where I had a diagnosis of NOWS. 2010, it was about 5.6. In 2015, we went to 9.5, and in 2017, we were up to 15. So our numbers were climbing per capita at a much greater rate than other states across the country. What's unique about Rhode Island itself, though, is that a majority of these children were able to receive care at one facility, and that facility was women and infants. Only recently have other birthing hospitals in the state started to take care of infants with NOWS and not transfer them up to women and infants. So more than 95% of them will be cared for at women and infants. Newport Hospital is the only other hospital that will keep infants in the hospital and treat them for NOWS. Other hospitals such as Landmark will do, and Kent will do observations, but should a child cross treatment, then the babies will be transferred up to women and infants. What's nice about our state and what's nice about our system of care is that we provide our care for NOWS in the nursery. We don't provide our care for NOWS in the neonatal intensive care unit. This is a new trend. We were on the forefront of this trend. We've been doing this now since I believe it was 2010, 2011 when Dr. Padbury implemented that change. But a lot of other hospitals across the country are now really starting to realize that NOWS is not an intensive care unit problem. It's a promotion of mother-baby bonding to help support infants, and the best places to promote mother-baby bonding are not NICUs but their nurseries. And so bringing these babies into the nurseries is really the first step of treatment. So that's a little bit of a background of NOWS and NAS. I'm going to jump into our COBRA projects. So our first
Adam, just one quick question. Is that,
Yes.
What proportion of those children are on prescribed medication to the mother versus illicit medication? Because it's going up, but during that same time we had an increase in the use of methadone and buprenorphine. And I'm wondering if that's the clinical course is probably going to be different because of the half-lives.
Well, I got to say, it's really, Joey, that's a great question. And it's a great question because it's not a very straightforward answer. Across the country, classifying the type of exposure by medication is one way that people have really tried to look at if it was prescribed or if it was illicit use. However, some people will classify it just by the medication itself and not, or how a medication was acquired and not the medication itself. So someone who might be acquiring methadone from a friend, they would classify that as illicit use and they would just lump it into illicit use versus prescribed use, where others are classifying what is the actual exposure. Is it methadone? Is it buprenorphine? Is it OxyContin? Is it heroin? And then classifying the signs and symptoms of NOWS based on the medication exposure, but not the way that it was acquired. The other downside, too, is that there is no unified term or agreed upon term for what is the severity of NOWS. And because there's no agreed upon term for the severity of NOWS, a child who's exposed to, we'll just say heroin for this example, they might show signs and symptoms of NOWS within the first 24 hours, but their length of treatment that they would need might only be days. And a baby who is exposed to buprenorphine in utero might not show signs and symptoms of NOWS until the 4th or 5th day of life, but has a 3-week hospital course. So how do you classify what is the severity of NOWS? Is it the onset of withdrawal, or onset of signs and symptoms of NOWS that needs treatment? Is it the length of treatment? Is it the highest Finnegan score, which is a subjective measure of withdrawal? So it's very hard to even really talk apples to apples with other colleagues because you have to have an agreed upon definition of what you're going to be discussing, and that just doesn't exist currently in the literature. Before I go further, any other questions or comments? Okay. So As part of our project, we have embarked upon a qualitative research project really to get the perception of opioid use and research from families that are being observed for nows. A lot of the trials that have been conducted, a lot of the literature that's out there, is really telling the story for the mothers without even really discussing what the mothers are saying. And so we embarked upon this qualitative trial to really be able to gather the perceptions of the families themselves to try to see if we can come up with themes that were important to them, not just themes that we perceive to be important to them. So the focus of the project was to develop a better understanding of maternal perceptions of opioid use in pregnancy. And we also wanted to try to further understand the partner perception of opioid use in pregnancy. As part of that, As part of that, we had 3 specific aims. The first one was to develop an understanding of the maternal perception of opioid use in pregnancy. The second was we said paternal, but really the partner use of opioids in pregnancy. And then really just to also understand their appreciation or understanding of being involved in research. And this is because when we look at trials that involve nows, they have exceptionally low enrollment rates. And there is a sense of mistrust that has really been talked about within the medical community about families wanting to be involved in trials that has anything to do with nows because they're worried about the real or perceived negative consequences of being involved in a research trial. And so we really wanted to explore, learn more about it to see if we could approach our research differently or try to find ways to minimize this perceived negative effect of research on them or their infant. So for this project, starting just with our progress, starting with the IRB, we submitted in July 2019. We had our initial review in August 2019, not 2020. And then we received our conditional approval in September of 2019. Part of that conditional approval required us to go to the lifespan because of the partnership with Dr. Ramsey and her team. And the Women and Infants IRB felt that lifespan was going to have a relationship with the study, and they wanted their approval. So we ultimately didn't get our final approval until January of 2020. We jumped right into the project, and that, up until we had to suspend our services because of COVID, we were able to get 6 mother interviews and 3 partner interviews. However, because of the COVID epidemic, like most research in the state, we've had to suspend it. And at the moment, because of our suspension, we've really tried to further develop the code book for our trial, tried looking to see if we can pull themes out and start to classify some of the statements that were made into different themes. And in addition to that, we're also resubmitting, it sounds silly to say resubmitting, but we're to ask for approval to restart our project. We tried to do this a few ways. One, we wanted to know if we could adapt our trial to using Zoom as our mode of communication with families for the interviews. They said no, that all research activity was suspended, so that was shot down. The second one was we wanted to really try to pick out we wanted to get some better clarification on some of our themes, so we wanted to regroup and go back to the families to get further clarification over the phone, and the IRB declined to let us do that as well. So hopefully once we get back open to research, we'll be able to press on with this project, because I have to say, looking at the code book, looking at the preliminary information in the code book, there is great themes out there, and there's great comments that I think could contribute as a whole, not just to our projects, but the literature as a whole, to get a better understanding of the mother's perceptions of how healthcare is treating them and how they perceive their opioid use during pregnancy. The second project that we're working on is what we're labeled as the Tri-Mor-Bup protocol. It's a randomized control trial for the treatment of nows. The trial is going to be comparing 2 that are used in current practice. One is morphine, which from a large multi-center retrospective chart review, more than 65% of centers across the country use morphine. And then the other one is buprenorphine. While it has the lowest number of centers using it, there was a great meta-analysis of the current literature that was performed in JAMA that really showed that buprenorphine has a lot of great potential in NOWs. So we're going to be comparing the most common medication with the medication with the greatest future potential. The trial is also going to be looking at neurobehavioral and neurodevelopmental outcomes for the infants that are treated. Short term, at discharge, we'll be looking at something called the ENDS exam, and then long term is going to be the 18-month Bailey. The ENDS exam for the group is a neurobehavioral exam that's used to evaluate the neurologic and behavioral functions of infants, and it observes them across multiple domains. We wanted to look at the ENDS because Dr. Lester and his team have really shown that the ENDS has a great predictive value for future outcomes, and because the ENDS exam is done at the time of discharge from the hospital on the infant, it really takes into account the infant's state and not the effect of the social after discharge on the infant's development. And so this is a graphic that is showing the effects of opioid exposure on infants. Now, when you look at this graphic, along the x-axis are the different domains. Along the y-axis is the standard deviation, and the colors, the blue, the red, and the green, those are different types of profiles that can be formed when we do an ENDS exam. If you look at the green profile for this graphic is labeled as profile 3, but the green profile 3 here is really the abnormal profile. And when it's the abnormal profile, because infants who show this characteristic profile have difficulty with handling, difficulty with regulation, disruptions in their arousal and their sleep-wake cycles, their increased excitability, they have a harder time with stress abstinence, and the quality of movements is very fragmented. So for infants who show this profile, they're in the highest risk group. When we did our former study, the baby trial, comparing morphine and methadone, we found that infants who were in this profile 3, were also the infants that have the longest length of stay because of NAS, and then also the longest lengths of treatment. Ironic here was that this profile also had an asterisk to it for the morphine-affected infants. That infants that were treated with morphine in profile 3 had longer lengths of stay, longer lengths of treatment, longer lengths of stay due to NAS compared to their methadone counterparts. So we really did start to see a drug difference, not just an NAS difference. When we looked at Bailey composite scores, 18-month outcomes for infants that were treated with either morphine or methadone, we didn't see as much of a difference in 18-month outcomes between the treatment arms. But when we compared infants to a normative sample, so infants with no medication exposure whatsoever, we saw once again in the morphine arm there was a decrease in language scores overall. And the decrease in language scores were really significant, almost double the normative sample. So this really gave us hope to think that it's not just NAS, but it's also drug effect. And even though morphine is the more commonly used medication, that retrospective study, that meta-analysis that was done and showed that buprenorphine had the greatest potential, we thought, if it has the greatest in shortening treatment, does it also have the greatest potential for long-term and developmental outcomes? And the fact that our previous work showed that there can be a drug effect gave us, it was very encouraging to want to see if we could improve the developmental and behavioral outcomes of infant beyond NAS, but with drug treatment. So for our Tri-Mor-Bup progress, we have completed the fiery hoops that the FDA has thrown us through, and the last one was they just wanted a quality sample done on our specimen, but that no longer is going to need to hold up our trial. That can be done as long as it has to be accomplished before the trial is complete, but it does not have to be accomplished before the trial can start. So because of that and because of that motion, we've been able to really press on. We've had some challenges because of women and infants' perception of data risk with how data was going to be shared, and Brandon and his team have been phenomenal helps and supports to help guide us through this. And so what we've ended up being is that the Brown Center will be storing the data. That way none of the data is leaving technically women and infants, but Dr. Marshall and his team will be overseeing the statistical analysis. And then our was done in June 4th. We got our pre-review letter, which we've addressed. A lot of the things simply had to do with the research application and some of the questions as it pertains to the protocol, and we've made those modifications, so we're just waiting our final outcome letter from the board.
That's great, Adam. Thank you.